Leishmaniasis is actually a really common disease. It's actually one of those underappreciated diseases which creates a big burden of disease. It's common in Africa, in Asia, and in South America. It's a parasitic disease caused by the Leishmania parasites. And there are actually three basic forms. There's a cutaneous form, which is by far the most common one, but it's not very severe, which leads to sort of nodules and ulcers on the skin. There's a mucocutaneous form, which sort of attacks mucous membranes at the dermal interface between mucous membranes and skin, which is a bit more towards South America. And then there's the most severe form, which is the visceral leishmaniasis form. And this is a form where the parasites actually go in the body, create big lesions within the liver and spleen, and create fever and quite severe disease. And if untreated, has got a very high mortality rate. Worldwide, there's approximately about 350 million people at risk, so there's a huge amount of people at risk. There's probably about 100 million cases per year, of which 1 million is about symptomatic, and of which about 350,000 to 400,000 actually have the severe form, the visceral leishmaniasis, which requires treatment, or else it's a lethal disease. The disease mainly occurs in East Africa, in the Horn of Africa, so in South Sudan, Ethiopia, Somalia, northern Kenya, in that area of Africa, but also in India, in Pakistan and Nepal, in that sort of area, so those two are hotspots, and also in Brazil. And some mucocutaneous forms actually occur in Brazil, in Bolivia, in Peru, sort of in that middle of South America. It's an interesting disease because it's spread by the sandfly. So it's a vector which is a really poor flyer. It's very lightweight, it's got a bad flying capability as such. And small gusts of wind could easily blow it around. But nevertheless, it transmits the disease quite efficiently. People which are living in poor circumstances, low resource setting, poor hygiene, which would allow the mosquitoes to breed and replicate, so they're more exposed to the disease. Migrants, for example, people on the move. And then there's people who are at higher risk of severe disease. Those are people that are immunocompromised, like HIV, or people under immunosuppressive drugs, or people with chronic diseases. So I've got to stratify into the three main symptoms for that. So the cutaneous form basically is an ulcer. So it's a little sore which starts off at the bite site of the mosquito, of the sandfly, and then develops into a slowly growing, expanding ulcerous lesion. There can be multiple ulcers. They can be in the face, on the body. They can be very stigmatizing because they can grow to be very large. They're not really painful, but to diagnose the etiology of such an ulcer, you need to make a little skin snip and look for the parasites within. It's very responsive to treatment. There are some spontaneous remissions, which is also quite common in the cutaneous form. The mucocutaneous form is a bit more difficult to treat. You distinguish actually between the uncomplicated and the complicated mucocutaneous forms, and they require more dedicated treatment. The cutaneous form can be treated more locally using infiltration of drugs, or just thermal or cryotherapy, so local heat or local cold, to scurify the lesions. Whereas the mucocutaneous form really needs systematic treatment. And the third, the more severe form, the visceral leishmaniasis, causes fever, it causes anemia, it causes inflammatory response, generalized, with enlargement of the liver, of the spleen, and actually can cause a very severe form of disease. However, if you treat it properly and correctly, there is still a probability that you get a skin lesion, a skin disease afterwards, which is called the post-Kala-Azar dermal leishmaniasis, which it's a very interesting disease. There's a bit of an enigmatic disease. Not everything is quite clear about this yet. But it definitely results in a very high parasite load in the skin, which then leads to sandflies taking up parasites again from humans, getting infected, and then passing it on to other people. So it's an anthropophilic transmission route. Originally, it was treated with antimons, so they're quite toxic drugs based on arsine. These are now not really used anymore. There's now a shift towards using liposomal amphotericin B, which can be given intravenously. However, this is quite an expensive drug, so it's not, it's not very widely accessible at this stage in time. You can use miltefosine, which is an oral drug, and they work pretty well, these two drugs. The antimons actually have a cardiotoxic side effects. It can induce cardiac failure. You can have allergic-like reactions to these drugs. It's dose dependent, so the higher the dose is, the more drug you administer, the more likely you will encounter these side effects. You need longer treatments, pancreatic side effects as well, as I said previously. However, with liposomal ampho B, it's become much easier to treat, and side effects are much less. But this comes at a higher cost and access to the drug. Because it's transmitted by the sandflies, obviously you need to make sure that they don't get to you. So using repellents is a very wise choice for travelers, especially. Sleeping under bed nets is important. The sandflies are outside usually, so whenever you go outside, that's the time where you need to be protected. Unfortunately, there is no vaccine. There is a vaccine which is used to vaccinate dogs because they're hosts and they can, for certain forms of Leishmaniasis, but not for humans at this stage. I think the major challenges at the moment are really in optimizing drugs, diagnostics, and vaccines. Those are this obviously goes for almost every infectious disease, especially in tropical medicine, but this is the hallmark approach. So in terms of diagnostics, there's only a really cheap, affordable, point-of-care, rapid diagnostic test available for visceral Leishmaniasis, luckily for the more severe form. It's very easy to use, but the problem is it's based on antibodies, and in an endemic area, a lot of people have antibodies, and that can lead to false positive results. However, you can use this test also in urine, and this makes it a more useful test. So having better tests, less expensive tests to diagnose early and then induce treatment is really important. And the second thing, obviously, is having new drugs, better drugs. There is research going on there as well. At the moment, obviously, liposomal ampho B versus miltefosine are the two major drugs in use. Combination of both are now being discussed. There are some new drugs which are actually used in human trypanosomiasis in the sleeping sickness area, which actually also have an effect in Leishmaniasis and can be used in conjunction with miltefosine to achieve an oral combination. So you don't need to give it IV as you would need to do when you give liposomal ampho B. We use liposomal amphotericin B as the most important one, I would say. It's an IV treatment, so you need basically to be hospitalized, you need an IV line for that. There is miltefosine, which is an oral drug, which is, at the moment, there are quite a lot of trials comparing the two. In one trial, one is better than one the other, so then there's not really a winner as such. But we know that the previously used antimon drugs, which have high toxicities, are increasingly not being used anymore because of the side effects for one, but also because there are increasing treatment failures associated with antimons. So there is a need for better drugs. Liposomal ampho B, initially it was ampho B, not the liposomal formulation, which is cheaper but has higher toxicity side effects. this shift to using the liposomal one has really led to a substantial improvement in the management of Leishmaniasis, and is actually, at least in the more developed settings, the drug of choice. As for most infectious diseases, research, especially in my world, as a clinician doing clinical research, has a translational focus. So you want to try and develop things which help the patient ultimately. And these are usually drugs, diagnostics, and vaccines. So obviously drugs are a big theme, Leishmaniasis, with increasing failure based on the antimons and the high price of liposomal ampho-B, and also from miltefosine. Obviously there is need for cheaper drugs, easier regimens, so ideally a single dose would be the most ideal, or at least once daily dosages, shorter duration of treatment. And there is a lot of research going on in that area. There is actually a drug which we have been evaluating at the Swiss TPH called fexinidazole, which is used for human African trypanosomiasis. It's a big breakthrough, by the way, for trypanosomiasis, but actually it's also a breakthrough for Leishmaniasis, because if you combine fexinidazole with miltefosine, you actually have a full oral regimen, which could be very potential, which could be very effective in treating Leishmaniasis. The hotspots for research in Leishmaniasis are in East Africa. We've actually got partners working in Ethiopia, doing a lot of work on Leishmaniasis, developing diagnostics, and doing drug evaluations there. So this is Ethiopia, South Sudan, Somalia, northern Kenya, sort of the Horn of Africa region. But then also there's a lot of work going on in India, also in Bangladesh and Nepal, but mainly in India. There's also the disease is spreading into Southeast Asia as well, and also in South America, in Brazil, but also Bolivia and Peru are some hotspots. So there's quite a lot of research going on in these areas. Obviously, research focuses also on surveillance to see if there's an increase or a decrease in transmission, if there are new forms, what the actual problems are, and especially focus on treatment trials currently. Because it's a neglected tropical disease, the incentive or the drive, the commercial reward for performing development of drugs, diagnostics or vaccines is quite low. At the moment, this research is mainly done by getting competitive grants rather than having sort of bigger programs which support large-scale research. But WHO is doing a lot of good work in this area, in the neglected tropical diseases arena. And I think for surveillance, there's some funding available, but actually to pursue better diagnostics and better vaccines, this is a true issue. Well, I think it's important to create a new generation of doctors who have experience in clinical research. I think it's a human resource issue in many places, because often you have clinicians and they do their clinical tasks and don't really have a lot of interaction with the researchers. So there's not really very strong translational benefit. And then there's a lot of research going on, but with very little interface to the clinics. So it's sort of a biphasic problem. And I think this would help if you had more researchers or more clinicians with a research interest, applying for funds, highlighting the need, making more studies into assessing the burden and the costs of these diseases. I think then discussions would sort of move towards getting better fundings.